warm all over. There's somebody other than y'all. Okay, let's talk about surgery.
Oh, that again.
Yeah, let's go back to the beginning. We're gonna talk about surgery. In order for your patient to go to surgery, they have to have a consent. Before you can get consent, there's 3 things that you have to make sure of. What are those 3 things?
The patient is awake.
Alert and oriented. And notice that does not say ×4, because our patients do get confused sometimes, but if we can reorient them, they're good. Alert and oriented.
The patient has to be aware of what is happening. They need to know.
I mean, the doctor already explained, right?
But you have to make sure they understand risks, benefits, and alternatives. And they have to be able.
Over 18?
Yes. Unless,
Emancipated.
yes. What can cause your patient to not be alert and oriented?
Medication?
So why? So opioids, Phenergan, it's sedating, so anything that's sedating. Xanax, Ativan, all those good things. So you got the consent sign for your patient that's going down to surgery. Before you send them, you gotta look at your pre-op checklist. What are you gonna make sure is on the pre-op checklist?
Labs, vitals.
So know your lab values, please. So what are the major labs that we worry about in surgery?
PT, INR, potassium. Hemoglobin.
Coagulation studies. I'm just gonna put coagulation studies. You wanna know an H and H. Make sure you know what the BUN is, because if their kidneys are not working, they can't get rid of the anesthesia. They're gonna have a problem. My glasses are fogging.
Yeah.
I cannot see y'all. And we do wanna know what the potassium is. Why? Why is potassium so important?
Because the heart, causes arrhythmias.
Always. Look at this. And something else you really need to make sure of, there's no signs and symptoms of infection. So look at their white blood cell count. If you have a patient that comes in and they have sniffles, they have a cough, you wanna let the surgeon know. Because if they're already compromised with their respiratory system, what does anesthesia do?
The what?
Causes
If they're
respiratory
compromised?
depression.
Respiratory depression,
There's
so
pneumonia and all that.
that'll make it worse.
Wait, repeat that. If they are already
Respiratory compromised, anesthesia is gonna make it that much worse.
oh, okay, respiratory compromised. Okay,
So if they have that cough, sniffles,
okay.
running a fever. So you've got your pre-op checklist done. You're gonna take away certain things from your patients. What do you wanna take from them?
Belongings.
They need the ear pieces.
And what, are you gonna just leave it in, or are you gonna notify somebody?
Notify them.
Notify them.
So all patient belongings are going to go to where?
To the family, no?
Yes. Belongings with the family. Leave your hearing aid in and notify the nurse.
And the teeth?
Take them out. They don't need them. They can't eat. If any of your lab values are off, who are you gonna tell? Are you gonna tell that nurse that you give a report to?
The provider, the
You have to
surgeon.
call whoever the surgeon is that's performing the surgery. Your patients are ready to go. We're sending them off down to the OR. What does the OR need to know about this patient?
What
They
was
already
that?
know what they're coming for. What else does the OR need to know? Allergies. And it's a big one.
But are,
That's when
don't-
you're turning, when you're,
Get
Give
ready
a
to send them
report.
off. Mhm.
But don't they know because they have that information? No.
You have to tell them.
Okay.
It's in the chart, yes, but because Your patients that are going under anesthesia have a higher risk of having a latex allergy. You wanna let them know if your patient has a latex allergy. Call them and let them know so that there are no latex products in the OR when they get there. In the OR,
So-
you have, okay, go ahead.
when are you doing that? When you're giving report, you're telling them about allergies?
And you're handing off,
And now, if you
post-
don't give report, it's gonna be on that pre-op checklist. Because
Pre-op
sometimes
checklist.
you can't get a hold of them and they can't get you. So always make sure it's on your pre-op checklist. So your patient's on the way to the OR. There's 3 people in the OR other than the surgeon and your anesthesia provider.
Your
Who are they?
circulator.
Circulating nerve.
What is your circulating nurse? Whoa.
She's not sterile.
She's not sterile, but what's her role?
count,
The checkout, the timeout, is it the timeout?
Timeout, instrument count, I heard. One more. That's really important with these patients.
Consent.
We already
make
did
sure the
consent.
right
Position.
side, right,
Yeah, check
right
the
side,
body.
right
That's
side,
part of your
That's what
timeout.
Positioning, no?
That's
positioning?
Position.
Yeah, cause they gotta make sure that the limbs are, you
So you
know.
don't wanna overextend anything, because
Mhm.
then you can damage nerves. If they've had injuries to the hips or they had a hip replacement, you don't wanna overextend that either. So they're gonna put padding to keep them from a lot of pressure, and they're
Yeah.
gonna
Like we
hold them
had
down to the
a
table.
patient that went for like a mastectomy, she came out with a big little, a decubitus like in her head, and I was like, what happened there? She's like, no, they forgot to put,
Wow.
like, extra
You
padding.
have to pad them, you have to pad them and hold them, tie them down. So if their arms are on the board,
Divina.
so it doesn't fall off, tie them,
Mm.
position tie. Then you have your scrub nurse. What does your scrub nurse do?
She's the one that gives the instrument to the surgeon, sterile nurse?
She is sterile.
Oh, the circulating nurse is not sterile?
No, she's outside the field.
Not sterile. So your scrub nurse, you said hands off instruments. And what else does she do? Important part of her job. Safety. She's the second instrument count. She's the one who's touching the instruments because your instruments are sterile. And then the circulating nurse is gonna be standing there with either paper writing it down or with her computer and writing it down. Her count and her count are his, however, their counts need to match. That's all you need to know about the OR. That's it.
About the OR?
Mm-hmm.
I don't know.
Now, PACU,
For one day.
when your patients go into PACU,
Hmm?
what's important? What's the
PACU.
first thing you wanna do when they
PACU.
come to PACU?
Right.
Vitals.
No,
Ah! Why not?
ABCs.
Airway.
Yes. Because
Turn them on the side.
remember, they have been
Oh, that's
sedated.
right.
They are not able to maintain their airway sometimes, so you need to check their airway, and you're gonna lay them what way?
On the side.
Which is called
Lateral.
lateral.
So you do that even before you take the file?
Yes, ma'am. Airway is more important than just
So,
vital signs.
When they come into PACU, where I work, the patient comes in laying supine,
Forget
always.
what you do.
First thing they do is start hooking them up.
Forget what you do. Your first is to make sure their airway is paid.
By
Remember,
doing
E-Place is
what?
all about
By doing
safety.
what? What do you
Put
do?
them on the side.
Looking.
By
You're gonna
looking?
flip them
Assessing.
over, and you're gonna assess for their respiration, their O2 sat, make sure there's no obstructions, that they're oxygenating well.
But what if they had like a surgery, like a hip replacement or something, that you cannot lay them on the side?
Then you just don't wanna lay them supine, you wanna tilt them a little bit.
Onto the post, not the operative
non-operative
site, the
site.
non-operative site.
This is due to vomiting, correct, or?
Yeah.
Am I right,
It's-
no?
It's partially for vomiting, but if they're laying to their side, you can tilt their head up and it opens the airway up more. Versus if you lay on your back, so with your sleep apnea patients, remember, we don't put them on their back because they collapse. Same thing, every patient's gonna collapse when they're laying on the back, it's easier to breathe on their side. So, patient come in, we check their airway, what's number 2? This is number 1. Yes, thank you. We're gonna check for bleeding. How do we check for bleeding?
Observe the operative
Inspect.
site. No?
And measure.
Measure.
Bleeding on dressing. You're gonna measure that bleeding. If they have bleeding on the dressing, you're gonna circle it and monitor and see if it gets bigger or not. If it is saturated, they're bleeding a lot.
Do not
We
take
need to
it
put
out.
a fresher dressing in, try and get them to stop bleeding. First dressing is changed by who?
The doctor.
Yes.
If saturated, we need to what?
Reinforce and pressure to try and stop the bleeding. So after their airway's good, they're not bleeding, then you can get your vital signs. So these are your priorities in PECU.
All of that, and what if the patient is like coldy and stuff?
Then they don't have a good airway if they're cold, do they?
Or do they come in with already like, no, cause she said you have to hook them up. So you do that quickly.
I mean, that's the first thing. Anesthesia typically comes out with the patient. The OR nurse anesthesia, the first thing they do is just grab everything and hook up the patient. They don't turn the patient or airway or nothing. They just, so I'm
They
wondering.
might be choking and they don't even know.
We all take shortcuts. as
It's
hard as
true
it is
though,
to
because
say,
the patients come out
everybody takes
zonked. So you don't know if they're breathing.
But yeah,
Mhm.
airway is your priority.
Until you hook them up to the
Right.
I'll be like,
Which happens,
The
yeah.
patient comes in, we check airway, we check breathing, their vital signs are good, we're gonna send them out to the floor.
Mhm.
What are they at risk for when they go out to the floor?
Yeah,
After surgery, what's our high risk?
yeah, infection,
DVT.
bleeding,
DVT.
oh, DVT.
And
Pulmonary pneumonia or whatever.
atelectasis. So, what do we wanna do?
What is PMA?
Pneumonia, sorry.
Oh.
Yeah, you have to kiss, I'm so sorry.
Pneumonia, atelectasis.
So, we're going to ambulate from this one, and this one, and this one. All of it, it helps with all of that.
To prevent.
To prevent.
For the atelectasis, you need a center spirometer.
Yes, I was gonna say, let's keep going. So, incentive spirometer, SCDs. Turn, cough, deep breathe, turn, cough, deep breathe.
The moving
Oh,
nose,
the
stop.
compression zone.
What's
What?
SCD?
Compression zone.
Yeah, the compression dressing. Range of motion.
And what is the IS? I'm sorry.
Incentive spirometer.
Oh, okay. Incentive
Turn cough
spirometer, also for the pneumonia.
Mm-hmm.
And,
Turn
So
cough.
if you can
Turn
get
cough.
the atelectasis clear, they won't go to pneumonia, so that's why you do the same
TCOB,
thing.
turn cough,
Deep breathe, that's a
deep
deep.
breathe, turn cough. I'm sorry, I'm
No,
not used to
You
that.
good. If your patient has an abdominal incision, what is gonna be the big concern with them?
Pain
Pain.
and
So how do we know with that pain?
Splinting or
Splint.
the
And what are we gonna use to splint?
A pillow,
Or
a rolled up blanket.
a bath blanket, so a pillow or bath blanket.
Split, that's for splinting when they have an abdominal,
Mhm.
right?
Abdominal or even a chest, so if your patients, like we had our patients that had cabbages, it's the same thing. So splitting helps with pain. It doesn't help clear the airway as much as the tongue, because the deep breathing does, but splitting is what helps with pain. How far up should we elevate our patient's head to prevent atelectasis? 45, good.
45.
And how much fluids do we wanna give?
2 to 3 liters.
For
What is it?
Fluid, we wanna give them 2 to 3 liters a day. To help with thinning out their secretions. So with atelectasis, what happens is you have mucus build up a lot of times. And that mucus can't come up because it's too thick, so if we can give them more fluids and thin it out, then they can cough and get it up. That is all for surgery. Anemia.
The thinning the secretion.
And I'll send y'all a copy of my notes too.
Oh, thank you.
Okay. Plastic. What labs are we gonna look at?
Hemoglobin.
Hemoglobin, hematocrit.
H and H. We're gonna look at H and H on these patients.
B12, no.
And with aplastic anemia.
The hemoglobin, because I think they have too much. No.
All of them. So A is without, like, so nothing. They have nothing. So we're gonna look at white blood cells, red blood cells, and platelets. Who's at risk for having aplastic anemia?
Chemo patients.
So let's just kind of put them all in one category. Immunosuppressed. So that could be your cancer patients, that could be people taking long-term steroids, they can be your HIV patients. Anybody that's immunosuppressed. Who's at risk for pernicious anemia?
The gastric bypass. Yes.
What are they missing?
The enzyme.
Intrinsic factor.
The intrinsic factors. Not the sleeve, but the bypass.
It can be that one too, because you can have part of the stomach and they don't have the intrinsic factor in there. So any kind of gastric surgery. People who take proton pump inhibitors, because it suppresses that. And, I can't spell. Please forgive my spelling. And your vegans. Who's at risk for anemia?
Pregnant.
Yes. Pregnant.
You learned something on
And that's it.
All of us indeed. Who do menstruate, for diet. Very good. Guess what, I'll kind of- How do we treat?
Infusion.
We're gonna do the infusion first? We're gonna do something else first?
Iron supplement?
Yes. So if we're given iron supplements, what are we gonna take iron supplements with?
With a straw.
How's it
Orange
oranges?
Oranges?
Citric acid, citric juices. So you gotta have that citric environment or that acidic environment for it to absorb. So put the citric acid or juices on an empty stomach because your stomach has a lot of acids. Now, if the supplementations don't work, then we have to do the iron liquid instead of the pills. Straw because of what is it?
Stains your
The stain in the teeth. If that doesn't work, then we might have to do a transfusion or some iron. How do we treat our patients with pernicious anemia?
Blood transfusion.
We're gonna give them some B12 powder. How?
Yes, shots, injections.
Yep, injection or
Injection.
intranasal. As long as it does not have to be absorbed, because if we give them to them orally, it don't matter, cause they're missing that intrinsic factor. So we have to get it somewhere that it
So
doesn't need to be
that
absorbed.
anemia is a deficiency of vitamin B12.
This one?
Yeah.
Yes, it's a B12 deficiency, but it's because they don't have the intrinsic factor that helps absorb it. So no matter how much you give them, because they don't have the intrinsic factor, it won't go up unless you give it to them an alternate way. And how do we treat these patients with aplastic anemia?
Hemoglobin?
Is it blood transfusion?
We're gonna treat whatever their symptoms are. So if their white blood cell counts are low, we're gonna put them on neutropenic precaution. If they're high, they're at higher risk for infection. If their hemoglobin and hematocrit are low, we might have to do transfusions depending on how low it is. If their platelets are low, we may have to give them platelets. So we're gonna treat whatever symptoms they show up with. The only way to truly treat this is a bone marrow biopsy. So if your patient has a bone marrow biopsy, they're at risk for bleeding. How do we control their bleeding?
Wait,
Pressure. So we're gonna lay them, we're gonna use them to create their own pressure. So you lay them on wherever that injection site is and let them put pressure on that site. And since we're talking about bone marrow biopsies at the moment, for your patients who have Hodgkin's lymphoma, we're diagnosing it through a bone marrow biopsy. What are we looking for?
Oh, those
The birth cells.
Reed
Reverse.
Sternberg.
and that's for the
So Hodgkin's
Is
lymphoma,
it
we're gonna look for Reed
know?
Sternberg cells in that biopsy.
I don't
What are
think
their
so.
signs and symptoms?
No, it's okay. It's okay. It's okay.
What are the signs and symptoms of Hodgkin's lymphoma? Are both either Hodgkin's or none? Reed.
So the Hodgkin's lymphoma is the Reed Sternberg.
Sternberg cells.
We're gonna do bone marrow.
Reed Sternberg cells.
We see those there, and we're gonna look at signs and symptoms too. So, what's gonna make you think Hodgkin's versus TB?
Mm.
Because both of these are gonna have fevers, night sweats, anorexia. Same thing, same signs and symptoms. Fever, night sweats,
a cough.
coughing, what else?
Blood,
Yes. Get blood, tinge, sputum. And sometimes they will have a cough. And where do they come from? So you look at your risk factors. Did they come from a shelter? Were they in a jail? Did they live in a nursing home? Have they come from a country that has high infection rates? That's how you'll kind of know which test we want to run. They can be a hospital or a nursing home. Homeless. How do you diagnose TB?
with the sputum collection.
What are you looking for?
The
That's
culture.
bacilli.
Acid fast bacilli.
Says
How
the
many students are
sputum,
we gonna get?
3.
sputum, culture?
Acid
Three.
fast.
Sputums. And we're looking for
3, no?
three. Mhm.
3, so.
Because sometimes you have a false positive or false negative. So you're 3, and you're gonna get them on 3 separate days. And if you do a TB scan test, does that mean that that patient has TB?
No.
If it comes back, what does it mean?
They could have had the antigen
So they've been exposed to
exposed.
That's what the,
BCG, the, yeah, BCG. I'm not gonna, something Camelin, but it's the BCG. For your patients that have TB, how do we treat them?
With the isoniazid, the right, is it right?
Uh-huh.
Right, yeah.
So now we're going into respiratory?
No, that's the treatment for TB, the medication. Rifampin.
That's still wrong.
We know what it is.
Something. Yeah, spell check me.
Yeah, don't worry, I
understand.
understand.
This one, I know y'all know, what are we gonna tell our patients to watch for?
The orange, yeah.
Orange colored. Body fluids. Can they wear contacts? No.
Orange.
If y'all missed this on the test, I'm gonna be mad.
Why can't they
If
wear
y'all
contacts?
missed this on the test, I'm gonna be mad. It discolors them.
They'll get changed, they'll get the color.
Iodized.
Yeah.
What do we?
Liver and
LFTs, which are liver function tests, and abdominal pain. This one?
the same thing like this.
And then your ethylbutamol.
Ice.
When did they get their eyes checked?
Before,
And
and then after,
6 months?
before and after starting treatment. It doesn't really give a time frame.
Before and after is all?
Mhm. Before, so you'll have a baseline, and then after, so that you can kind of check them. That is all for TB. Your patients that have HIV. Who's high risk? What are those high risk patients?
Drug users.
Hospital worker.
No,
Phlebotomist.
no,
No? The people that work in the lab? Oh.
So your highest risk is through sexual transmission and sharing of needles. So people that work in healthcare have a relatively low risk, and so do people who work in tattoo parlors. So it's unprotected.
High
sex,
risk is
and
yours?
IV drug users.
Sex,
Drug users.
IV, drug.
And what patient population has high risk sexual behaviors?
Adolescents? Adolescents?
Older people.
What?
Old people
Funky in the
coming
nursing
up
home.
as support service.
Because they can't get pregnant, so they don't think of birth control. They can't have kids, so they have the more higher risk. So if
Wow.
we see that ever again, who has the highest risk?
The
Older.
Your elders.
older people.
Okay, wow.
Oh my God. I never thought of that.
Me
Oh,
either.
yes. They be wilding out. Yeah.
If your patients have to go home and they have to take oxygen with them because their tuberculosis has messed up their breathing, what are you gonna teach them?
No
No
smoking.
smoking.
Please no smoking. What else? How often should they clean those nasal cannulas?
Every day.
They change it if they're sick. When they're not sick anymore, right?
Mm-hmm.
Okay, no smoking.
After that.
Clean.
Y'all know that that triangle is changed.
Yeah.
So after they've been sick and they are better, change it. Wanna clean it at least once a week. No smoking.
Sick after better. Okay.
Go ahead.
Change it. That means change.
Mm-hmm.
Okay.
If your patient has a PE, a pulmonary embolism, so if you see PE wrote, it is pulmonary embolism, not pulmonary embolism. That's a PE, always and forever. Then you have pulmonary edema, and write that all the way out. if your patient has a pulmonary embolism, what's happening?
There's a clot.
There's a clot in the lung, so they can't breathe. So what are we gonna do first?
Sit 'em up.
No, they can't breathe. Is that gonna help them breathe?
Sit
No,
them up.
oxygen.
High flow oxygen.
Mm.
High flow oxygen. And position.
Is it the high? Oh, yeah.
High Fowlers. You want them sitting up as good as they can. And then you can start your heparin. Signs and symptoms of a pulmonary embolism. They're gonna have some severe anxiety. They're gonna feel like they're dying. So, feeling
They are.
of death.
They are.
They can't breathe. They're going to have what type of sputum?
Blood.
Blood,
thin-
yeah.
With your pulmonary edema, what type of sputum are they gonna have?
Frothy.
And what are we gonna give them?
Well,
Diuretic.
Fluids.
No!
Oh no, edema, sorry. Ooh.
Diuretic. Want diuretics to get rid of,
Frothy sputum.
so they're gonna have the pink frothy sputum, not blood tinged. The pink will be like kind of blood, but it has to be frothy for it to be edema. Blood tinged for PE. So these patients, because it is, both are in the lungs, they both can have some dyspnea, they can both be hypercardic. But the big thing is that sputum production and this anxiety with your PE. So what's your priority assessment for this patient with pulmonary edema? What are you gonna assess for?
Heart failure.
Lungs.
Lungs, you're gonna have crackles.
Yes, so respiratory assessment is your big thing for your pulmonary edema, because they got fluid buildup. So listen to lung sounds. Is it gonna affect your heart? Yep, at some point it is going to. And the heart's gonna be working harder. Lung, heart, Lord Jesus, lung sounds.
Is there any similarities to them then? Other than the fucking food?
Now, I want you to know the difference, that's why I put them together. Just because they're both pulmonary, they're totally
I don't want the
different.
phone to
This
turn
is a
off when
clot,
recording it.
and this is swelling and fluid buildup.
She's the computer stupid.
Is it dying on you?
It is?
I'm sorry. Alright, so we're good with PE and pulmonary edema.